Thank you very much. And indeed, thank you for inviting me here. And after having listened to these two presentations, I think this is going to be very exciting and very and very interesting and intriguing. So I'm an epidemiologist. I have been dealing with low back pain epidemiology since the 1970s, and I think the world has not really ready yet in this field. An epidemiologist cannot really get rid of, a dog cannot get rid of its hair, and I cannot get rid of my role as an epidemiologist. So what I'm going to present to you in the beginning is some trends in occurrence from Finland, which I think are kind of an ecological view on low back pain. And then evidence of work-relatedness, evidence from what we have for chronic low back pain and sick leaves, evidence from intervention studies. I think Hege took my slides away, so I can skip them. And then I would like to discuss a little bit the nature of low back pain, because I think that's something that we have to keep in mind. It's a very problematic measure of morbidity. And then discuss in the end the questions that have been posed. This comes from WHO, and this is a very familiar figure for all of you, I think. So that the peak occurrence tends to be here in population surveys in 50 years, and then we can see a decline. I think this is Eastern European countries. This probably is I try to check these regions, Pacific areas, Western Pacific, and this probably is African region. I don't know if it's Africa or Asia, either one. But anyway, this is how the prevalence looks by age. We have an annual survey of representative sample of Finns done by the National Institute of Public Health. And so we have been able to follow the prevalence of self-reported back pain during the past 30 days among working age people since 1984. And you can see that there hardly has been any change in the prevalence. But then when we take a look by age group, we can see quite interesting phenomena. So we can see that the prevalence is steadily decreasing in the older age groups, and it's increasing among the young. And the gradient across age groups is disappearing. So something has happened in the society. The prevalence of physician-diagnosed back disorder may be chronic low back pain or a proxy to that. You can see a steady decrease in prevalence by the year. And we can see the similar phenomenon here. There is a considerable decrease among the oldest age group. However, here there hardly is any change among the young. In 1978, 1980, 8,000 Finns, representative sample of Finns, were examined very thoroughly in the mini-Finland health study, and it was repeated in year 2000. And here you can see the prevalence figures for low back pain during the last month among men. The figures are very similar among women. The differences are a little bit smaller for women than for men. And an interesting feature here is that we can see what we call a cohort effect. So this is a cross-section of population. So those who were 55, 64-year-olds had the maximum occurrence. And now the maximum is among the 75, 84-year-olds, which means that we have this cohort that has been transferred to 75 to 84 years age group. And something has happened in the society that has caused this change. There hardly is any change in the prevalence of low back pain. But when we take a look at chronic back syndrome, which is really based on clinical examination and prior history of these people, there is a change, a decrease in prevalence. And you can see the same cohort effect here. So these people are somehow different from others. And if we talk about primary prevention, something has happened that has prevented chronic low back pain in Finland. And this is one probable contributing factor. The structure of workforce has seen considerable change, so that the major changes are in the number of people working in farming and in manufacture. And instead we have an increase here in finance and services, insurance, and in public and other services. Was it right? Yeah. And there has been a shift from very heavy work to lighter occupations in Finland. Of course, there can be some other things. One thing that we have been discussing is, we know from the Finnish army recruits that their physical condition is going down all the time. So the sedentary lifestyle of young people, I think in the Nordic countries and in all industrialized countries, may be behind this increase of low back pain also, but we haven't really analyzed these data yet thoroughly. And then I have a series of slides on the evidence. These probably are quite well known by you. I think we have 4 quite comprehensive reviews, and I have here, in a way, review of these reviews. Some of them are more rigorous than the others, but the conclusions you can see here. So that we have quite strong evidence for manual materials handling and lifting to be associated with low back pain. Hansen and others, they divided this into 2, so that heavy lifts often more than 15 kilograms or less than 10 kilograms, even if often. And they concluded that there is strong evidence for these heavy lifts and no, strong evidence for no increased risk for lighter loads. Strong evidence for bending and twisting, moderate evidence or limited evidence for heavy physical work. I think this is quite kind of an overall estimate of workload. And then from moderately strong to strong evidence for whole body vibration. As to psychosocial factors, the picture is more scattered. There's the estimates are from evaluations from weak to strong evidence for low social support, strong evidence for job satisfaction, and Hansen's group concluded limited evidence for stress and anxiety. These are association studies, and of course we can always then discuss whether they are the causal factors or they are just indicators of risk. I'll come back to that. The 4th review reported attributable fractions. This is the National Research Council from US reporting this. And attributable fraction is actually a measure of impact, relative importance of certain risk factors on the occurrence. We can say that if we remove the exposure among the exposed, this proportion of the disease could be prevented. And of course then the factors should be causal factors, otherwise it doesn't make any sense. And here are the estimates for physical risk factors and the occurrence of back disorders. I think this is one of the problems in reviews, so that there are multitude of health outcomes that are used, so that we don't have homogeneous groups That makes it a little bit difficult to interpret these results. But anyway, you can see that for the free, in a way, established risk factors, the range goes from 11 to 80%. Now, perhaps at this point I would comment on the notion that I think Johan said, that we have these low risk factors and professional epidemiologists wouldn't appreciate them. But I think when we have such a common health measure as low back pain, even theoretically, we cannot expect high risk ratios. And for such a common outcome, even small effect sizes are enormous in the society. So it's like in environmental epidemiology, I think we have a little bit different gain than we have, for instance, in cancer epidemiology. Then for psychosocial risk factors, you can see that the attributable fractions are almost equally high, ranging from 17 to 69%. But then I think really the question is how much they are causal factors and how much they are factors associated with pain reporting and so on. I think Bill will address this question in his presentation. Now, WHO has made an estimate of burden of, in the global burden of disease report of proportional low back pain attributable to occupational factors, and it is as high as 37%. Now, you may some know that the Dutch group has used these data to estimate this at individual level, so that they propose an algorithm where you can give an estimate for a patient for his low back pain or her low back pain. What is the probability that it is work-related? So that is quite interesting exercise reported in Scandinavian Journal of Work Environment Health. Now I have a few slides on risk factors for chronic low back pain and sick leaves. Actually, I have taken here also 2 reviews. Not so many reviews have been done. And also one thing is that when we are talking about, well, now this is about chronicity. I'll talk about sick leaves later. Now there are some, for occurrence, some individual factors that have been identified. Psychosocial factors are listed here, and occupational factors are in accordance with what we had before. But then for chronicity, we have obesity, low educational level, high levels of pain and disability, psychosocial factors, distress, depressive mood, and somatization. And for Van Tulder's group's evaluation, job dissatisfaction, unavailability of light duty on return to work, and job requirement of lifting for 3/4 of the day. Now the other group could identify only distress or depressive mood, somatization, and some evidence for catastrophizing as the coping style. Anyway, I think the evidence is very inconclusive when we are dealing with chronic low back pain and its risk factors. As to sick leaves, this is from the SMASH study in Holland. The classification was so complex that I just have these pluses indicating relative risk between 1 and 2, between 2 and 3, and 3 or above. And it turned out that for long sick leaves, trunk flexion and lifts were strongly associated with these long sick leaves. But anyway, these physical factors at work became more significantly associated with sick leaves than the psychosocial factors. Low supervisor support was a risk factor for short and poor job satisfaction for long sick leaves. I think sick leave is so strongly dependent on the social security system of the society that the results from one country to another are quite difficult to transfer because we have so different systems in the societies. Here is another, this is French study. This study was carried out in electrical companies, and they found for sick leave, smoking, a high pain score, protective effect by social isolation score. This is kind of a positive social relationships that were protective, repetitive bending, and low social support were the factors that they found. So they have a little bit different view. But I haven't really seen any good reviews on sick leaves. So I just picked up these two recent studies. Now I think Hege presented quite a lot of this in her recommendations. So I think I really need not go deeply into these. The slides will be provided to you later. But there is a long list of different factors that have been studied. I think this review is nice in terms of differentiation of different outcomes, because the previous study combined all the outcomes into one review, and I think that's not very good for drawing conclusions.
Is that our paper? Taito et al.?
Yes.
Yeah. Okay.
Yes, it is.
Tori is our first name.
Yeah, yeah. It's your paper. Yeah. So I think this is much better than the other because you have differentiated the different outcomes. Yeah. And then also Hege presented the. Oops. Yes. Hege presented the conclusions on treatments of acute and chronic low back pain. So I think I'll just go through that. Now, as I already said, for epidemiologists and I think for many other people, for clinicians, this concept of low back pain is very problematic. It's very non-specific, and we haven't been able to develop algorithms to differentiate different types of low back disorders. And the most common outcome measure has been low back pain. This is the common model that we usually use when we are talking about work-relatedness of or physical factors in relation to low back pain. So we have exposure leading to dose in our body, and then the response modified by our capacity. Here is another model. This is produced by social scientists, and it's a little bit different. It takes into account the contributing factors and classifies them into distal and proximal, and this they call intermediate outcomes, which means organic conditions, acute or chronic, and then perceptions, motivation to report, and then finally we end up with reports of low back pain. What really is the measure that we are using? And for each one of these, there are proximal individual related factors, and then we have distal factors like work environment, for instance. Here, how people cope with their low back pain, how their families have been coping with their low back pain, cultural things in different societies, and here I could mention social security system that influences very much people's motivation to report. So when we are dealing with influencing low back pain reporting that we measure, we should really take into account all this complexity that we have. Here is a model for work-related musculoskeletal disorders given by Sauter and Swanson in 1995. I think this is quite nice. So we have tools, equipment, technology influencing physical demands and work organization. Then we have psychological strain, individual factors, biomechanical strain coming from physical demands, modified by psychological strain, and also modified by individual factors. And then all these, they influence sensation and attribution, labeling what we have for our sensations, and then finally the musculoskeletal outcomes. This is an intriguing study. It's an experimental study dealing with perception. They had healthy subjects, and they had a block that they could heat. And they put this heated object posterior on the posterior aspect of the lower leg. And when they had this 45-degree block, the VAS scale for the sensation varied from 1.2, I think, to 9.2. Same stimulus, a very different sensation. And they used functional MRI to study what happened in the brain of these subjects. They classified according to this them to high sensitive and low sensitive and moderately sensitive persons. And when they had this standard stimulus, the response on the thalamic level was similar among these people with high and low sensitivity. But when they took a look at the cortical response, that was correlated with their VAS evaluation. And I think when we are trying to study the etiology of a low back pain or whatever pain, we should really have the thalamic level. But we can't take a look at that, because then after that we get all this modification according to the model that I just showed, perception and motivation of reporting. And then finally to the questions. So is it possible to keep the notion of primary prevention? And my answer is that the available evidence indicates that there is considerable potential for prevention. And I would even say that for primary prevention. And I would argue this with based on the results that we have from the Finnish population, this kind of ecological consideration. Something has happened in the society that really has changed the pattern of low back disorders in the population. I think for low back pain, it is very difficult to differentiate, like we are talking about primary and secondary prevention, because we cannot differentiate the inception of the disorder and the aggravation of pain, as long as we are just dealing with pain as the outcome. One thing along these lines is that I think the current knowledge about low back disorders among the young are very interesting. And I think what we should really learn is to have young cohorts and follow them up, so that we would see what factors are related to the inception of the low back problems and then the natural course of low back disorders when people age. So for primary prevention, really, I think we should be dealing with this. Prevention of these kind of organic conditions, whatever they are. Perhaps Bill will elaborate this. Then, do we have evidence for chronic low back disorders being caused by work exposure? I think evidence is inconclusive. And in that respect, I would, at this point already, make the notion that I think the evidence base for recommendations is not very strong. And in the society, we nowadays would require evidence for particularly national programs. But I would say that we really need more good research before really having a good basis for our recommendations. I think the concept of chronic low back pain, as we now have pain lasting more than 3 months is very arbitrary and hazy, and in that respect I think we should learn more about these disorders. Then the questions how to focus prevention campaign. I think it depends on the goal. What are we after? Reduction of pain intensity, frequency, reduction of chronicity, reduction of sick leaves, reduction of pensions. I think for primary prevention the only way is modification of causal factors. There's no evidence that we will be efficient in terms of that. But anyway, the association studies indicate that probably there is some potential in that. For secondary prevention, modification of contributing factors. But I think here we are dealing with the whole complexity of low back pain, not just the organic condition, but perception and motivation. And I think early evidence-based treatment is always should be there. And then I think there is no simple answer to what are the best measures of the effect. It depends. And it depends also on the observation period, because if the period is short, you cannot really expect to have significant effects on chronicity. But you can expect change in fatigue and low back pain and perhaps even sick leaves, because if you can influence people's behavior so that they return to work and stay at work, then I think you can use a shorter observation period. But for instance, the chronicity that I showed for the Finnish population, you really need a long observation period to see that. So here I again have this picture, and I think we have to deal with all this complexity of low back pain. And then the question how to prevent long sick leaves and premature pensioning. My answer is early treatment and rehabilitation means to facilitate return to work, workability and motivation to work. And I think perhaps this is the most influential modification of social security system. I think in Sweden they've had experiments along these lines. We have just changed our legislation for pensioning and try to keep people longer at work. But then to finish about work and prevention, I think, for instance, if our goal, like our institute has tasked to extend people staying at work for 2 to 3 years by year 2010. So it's a very difficult task. But anyway, I think one of the things that we have to take care of is that we have decent work. And decent work means such work that people want to go to. It means good physical environment, good psychosocial environment, good organization, good leadership, and so on. So I think whatever level of prevention we may think, I think this is something that is beneficial, even if we don't have the evidence. Thank you.